So VESPA stands for Vulnerable Elderly's Pathways and Outcomes Assessment. So the reason we developed that was that there are a lot of tools to assess older adults in the preoperative setting, but unfortunately, most of the tools looked at post-surgical complications and mortality, and very few of them looked at functional outcomes, so meaning can the older adult stay independent and take care of themselves after surgery, and as well as geriatric outcomes, so develop a delirium, things like falls and malnutrition. So we wanted a tool that can more comprehensively predict outcomes that's uniquely important to older adults. Yeah, so we initially assess a number of different risk factors, different geriatric as well as kind of comorbidity of the patient. We also included the complexity of the surgery as well in the score, and then we did some univariate and multivariate analysis and identified the items that were individually predictive as well as predictive in the multivariable analysis. So we were able to then assign a scoring system and tested how well it fitted to the risk, to predicting risk in postoperative complications. Yeah, so when we do these predictive models, one way that we can use to assess how well does it predict an outcome is using the area under the receiver operating curve. And so a score of 0.5 means that it's not, but it's just as good as chance alone to predict the risk, and 1 is perfect prediction. So our predictor model was 0.76, and that's, you know, for preoperative risk assessment, it's pretty similar to some of the other studies, and such as there is a cancer and aging research group. It's called CARG, chemotoxicity risk. So the area under the curve of these these risk predictors that we use often is about 0.7 or above. Yeah, so the reason we developed this was that we know that unfortunately not every institution has a geriatric oncology clinic. Ideally, we would like to have it, but we don't. But we do know that a lot of large centers has a preoperative clinic. So a lot of surgeons send their patients to be evaluated in the preoperative setting in the central clinic, and that's what we have. So we thought that this tool is really well fitted for institutions that may not have all the resources to have a geriatric oncology clinic, but may have some that we think that this tool can be really easily integrated. And the reason we think it's easily integrated is that, 1, it doesn't require any special geriatric training. So you don't need a geriatrician, you don't need a geriatric nurse to complete it. In our study, it was surgical physician assistant that completed the assessment. And then 2 is that it's pretty quick. So initially when we did the study, we assessed more factors than what ended up in the scoring system. And that, even with a longer one, it took about 10 minutes or less. So with this score that's even more abbreviated, using only the variables that was predictive of outcomes, it probably would be even shorter. So, and then, for our institution, what's exciting is that we're actually integrated into the electronic medical system, so that we can then easily integrated into the documentation, as well as ordering different interventions when the risk score is really high. Yeah, I think it's, there are a lot of different geriatric assessment tools, and I don't think one is particularly better than the other. But I do think what our tool adds is the functional outcome that's assessed. But it really depends on the availability of the clinic. So for clinics that doesn't have a person to do the assessment, maybe a self-assessment, a patient-reported assessment would be more appropriate. But we are really excited about our VESPA, particularly in our institution and hopefully in other institutions as well.